Welcome to the show. How are you today?
Hey Andy, thank you so much for having me. I'm doing well. How about yourself?
I'm good. It's great. It's great to get you on the show. As is tradition, we normally start by getting the guests to just kind of go through their background. So, to kick us off, if you can walk us through kind of your career start and then bring us through to the current day, that would be amazing.
Yeah, absolutely. I'm a very early career physical therapist here in the United States. I'm currently working at New York City Football Club, just outside of the city. But I really got my start in all this after sustaining a career-ending knee injury when I was playing college soccer. It showed me the differences in evidence-based care, and that led me on this trajectory to where I am today. So I started out, I got my bachelor's in exercise science from Gannon University in Erie, Pennsylvania, where I'm from. From there, I went to the University of Pittsburgh for physical therapy school, where I got my doctorate in physical therapy. And then right after that, I went into a sports physical therapy residency at the Cleveland Clinic in Cleveland, Ohio, where I had the opportunity to work with athletes of all levels and all ages, high school, college, pro. And then now I am currently, like I said, at New York City Football Club. So a really fun trajectory so far, and really thankful for all the people that I've met along the way.
Cool. And obviously today, the kind of main topic that we're going to get into is MPFL injuries. How did that interest begin for you? Was it a clinical case that maybe started and sparked the interest?
Yeah, I'll say unfortunately it was a relatively complicated case that I had the opportunity of working with when I was in the physical therapy residency in Cleveland. When I was there, we had the opportunity to work with a very high level American football team, a high school football team that regularly won state championships. And there was a particular kid, he was the starting quarterback, and he had sustained a lateral patellar dislocation during the year. And this case that we're going to talk about today kind of goes through how we managed him non-op so he could finish that season and eventually win a state championship, but then how he eventually did need an MPFL reconstruction and how I took him through that rehab to get him ultimately ready to play very high level American football.
Okay, so let's kind of follow a clinical narrative and go through kind of the assessment piece first, or the diagnostic piece within that. For you, how do you kind of go about assessing these MPFL injuries? Perhaps if you're curious that one might have happened.
Yeah, so what's unique about this case is I was actually able to be right on the sideline right when it happened. Um, in the United States, sometimes it's a little bit rare for the sports physical therapist to be right there, but that's just the benefit of the residency that I was in. So I happened to be there right as he came off the field, and I was the first to assess him. And the first thing he said to me was that he felt like his knee had popped and came back into place. And at the time, I was actually unaware of his previous injury history. He most likely had had one of these back when he was a freshman that required him to have a cartilage restoration procedure, an Oates procedure done on his patella. And he actually told me that right after this happened. So it was it was kind of nice. It kind of set it up. It kind of oriented me to what was going on. So what I typically do first is I kind of clear the other ligaments that might be affected, ACL, PCL, MCL, LCL. Just make sure that those feel nice and stable. And if those all feel intact and I'm palpating joint line and I might not think, I'm not really thinking meniscus either, I do my thorough assessment in that piece. I start to think it's a little bit more extra articular, and because of his history, it points me a little bit more to the patella. And then especially because he told me that it felt like it popped and it came back into place. Of course, I'm not thinking that the femur is moving off of the off of the tibia and coming back into place. I'm thinking it's probably the patella at that point. Now, for him, he said that he got hit. And now a lot of these, depending on if you're high risk, you don't necessarily need that contact. It's like that valgus mechanism with some external rotation, and that patella is just going to slip out laterally. Especially, knowing that he potentially had this happen in the past and they did not rectify that MPFL the first time, which depending on your risk factors, they don't always do. It's kind of all leading me into this direction. So I'm looking at his knee. It's starting to swell up a bit at the top. And then I palpate just over that medial patella. and that medial femoral condyle, and it's pretty tender. And he doesn't want me to move his kneecap at all. It's kind of cluing me into, yeah, this is probably another lateral patellar dislocation. The cartilage is probably, unfortunately, pissed off again, and we're gonna have to go from there. Now, I do not know if his MPFL was intact before then. Most likely, it was not. But he still had that medial tenderness and that tenderness over that medial femoral condyle. So I guess the biggest takeaway from that is cleared all the other ligaments. Didn't really think it was meniscus. Take a look at the MOI, take a look at the history, and it clued me right into it. And then I had the luxury of an ortho surgeon on the sideline came over and thought the same thing that I was thinking. So that felt pretty good as well.
Kind of, we can come back into this case in a second, but what are sort of like the usual risk factors that you might expect to see or kind of maybe uncover in someone's history, at least, for these injuries?
Yeah. So for like the first time patellar dislocator, there's some anatomical factors that people might possess. They might have a very like shallow groove in their trochlea, the femur. They might have a kneecap that tends to ride a bit higher, and they might have a tibial tubercle that's a little bit more lateralized. And those are all kind of anatomical factors that might set someone up to have this happen to them. We also sometimes are going to see it in some of your younger athletes, particularly younger athletes with poor motor control, going into some of those moments that I was talking about before, the increased valgus, a little bit of external rotation, and then it's going to slip out. So I think it's a combination of anatomical risk factors and then also just where they are motor control wise in their development. Because this typically tends to happen between the ages of like 10 to 17. It's a lot more common in that age range. And this kid, I guess the first time that he probably did it, he was probably around 15, and then it happened again when he was 17. So he was right in that age range that it's more common.
I always think these are kind of interesting injuries in the sense that you don't always see a lot of them. Like, when I first qualified as a physio, I think I saw 2 PCL injuries in the first month of my clinical career, and then I can't remember the last time I saw one. Like you can kind of go through these hot streaks where you see these like slightly more rare or less common like ligamentous injuries. You can see one or maybe a couple, and then you might not see them for quite a long time. So for you, kind of looking at clinical literature or resources that might help inspire you for assessments, treatments, and just general management, where were you kind of shopping? Was there any kind of sports or activities that you were maybe reading about these happening more often or getting greater occurrences?
To be honest with you, the literature is relatively limited in this space, especially as it relates to higher level athletes. There's some literature in the adolescent athlete, but for this kid, the level that he was going to want to return to Division I American college football, like the literature is saying these kids are going back to sport 6 months, no problem. And based on what I was seeing with this kid, albeit he had some extra risk factors, I knew that it was probably going to take a little bit longer than that to get him fully prepared to what he needed to do. What I did was I leaned on the doctors around me to make sure that my progressions were biologically sound, that I wasn't messing anything up with the graft, that I wasn't messing anything up with the chondral issue that he had. And then I relied a lot on some of the basics from what we know in the ACL literature. Making sure to get the swelling down, reduce the inhibition, just doing the simple things really well in the beginning of rehab to make sure that this kid did well. Because a lot of that stuff applies. And once you understand, what to avoid early on, and that's what the doctors were telling me, just based on the reconstruction that they did and the patellar defect, and then what to focus on to get all the other deficits back, it became relatively clear. And that wasn't necessarily laid out in anything in the literature. I had to take it from a few different places, be a little bit creative with it, and then move forward with this kid.
So the rehab sounds quite, what's the word, it sounds quite familiar in some ways. If you've managed other ligamentous injuries, you can kind of look at the signs and symptoms and marry that with the surgical protocols.
Yeah, it felt very similar in some of the ACL rehabs that I had done in the past, especially some of the earlier things. Like, you're going to control the swelling, you're gonna get the inhibition down specifically in the quad that he was experiencing, and then you're maybe gonna be a little bit more careful about the movement of the knee, especially in some of the testing that you might be doing compared to the ACL. But it's relatively similar. I would say the only other thing that, if you're listening to this and you're thinking about doing this with an MPFL reconstruction that you might have, something that was a little bit different for this case was taking into account the patellar lesion that he had as well. And a lot of the times these kids, when they dislocate, they might have a rather significant chondral defect. So it also depends on how they're restoring that. And that adds a whole nother layer of precautions that you might have to take on top of what you're already thinking about.
For this particular case, how different did that make the actual rehab in a sort of more tangible way? Like if we sort of say there's this kind of fairly standard or fairly common way that we're, bringing lots of ligamentous injuries back in terms of like, once that sort of acute phase is over, we've got range back. Strength's quite a simple, consistent process across them. For this particular case, with those other things going on, tangibly or sort of more practically, like what did the rehab process look like, and kind of maybe the nuances that you had to make for that?
Yeah, so the thing about this was, unfortunately, this was the second injury to the patella there, and to the second chondral defect. So he had already had a procedure done, and we know some of these procedures don't honestly have the best long-term outcomes. I think we have a lot of room to grow in this space, and I hope it continues to move in a positive direction. But he had already had a procedure done, and then dislocated again, and then disrupted that cartilage again. And so at this point, the surgeon had decided to do a little bit more salvaging, and there wasn't, they didn't do another Oates procedure. He had already punched his ticket, unfortunately, for some damage down the line, to put it lightly. So the most that I dealt with was a bit of pain in some very specific ranges. So the surgeon and I had talked, and we agreed that earlier on we should probably stay out of some specific ranges, to let what they were trying to do calm down a little bit, and then also to try to get the pain down. So more specifically, deeper ranges and closed chain exercises, going into any of the deeper squats, and then specifically closer to fuller extension in the open chain positions, specifically in the first 8 to 12 weeks of rehab. So I took that into account into a lot of the exercises that I was doing, but also I took it into account in the positions that I was putting him in to test him as well. And so once we got past that threshold where I thought it was the surgeon and I thought it was biologically safe, I did start to load him in some of those deeper ranges and some of the more extended ranges in open chain. But I had to ease him there because he did deal with a fair bit of pain, even after we thought it was a little bit more biologically safe to put him into those ranges. Because at the end of the day, he was going to get into those ranges again when he played football. So I knew that we had to strengthen him through those ranges, but we had to be very tactful about how we got him there.
At what kind of stage for this particular case did it kind of smoothen out? Like you kind of got past the MPFL sort of nuances and challenges. When did it kind of get to the stage where you were like, all right, now we're on plain sailing, the rehab's going to be quite simple now onwards in terms of it's just going to be more progressive and less nuanced?
I don't know. I don't know if it was ever quite linear, because what would happen is I feel like we'd be in a relatively good place, and we'd have a week where I could load him in some of those deeper ranges and say in a closed chain position and yielding isometrics, overcoming isometrics. His objective measures would come up, and then the week after he'd come in and he'd be relatively sore. And we'd have to regress a little bit. So it was a lot of adjusting based on what he was feeling, and also a lot of communication with the surgeon for, do we think this is normal? Do we not think this is normal? Should we lean into this? Should we lean out of it? Now, of course, the farther on you get after the 12 weeks, he starts running, 14 weeks, you feel a little bit more confident in that you're not totally going to mess this up when you're putting him into those ranges, and knowing you're going to have to strengthen him through those ranges anyways. But it was a lot of communication between me and the surgeon about what we thought was appropriate and what wasn't appropriate, and then a whole lot of communication between me and the athlete and what he was feeling. And yeah, we did a lot of progression and regression through that phase. So I don't know if there's a time that I could tell you that it was smooth sailing, um, because again, this wasn't just your basic lateral patellar dislocation, MPFL reconstruction. There was a lot of other factors that we had to consider, especially as it related to that chondral defect in the patella.
Yeah, and with these kind of cases, or maybe with this case more specifically, once that player's kind of back and they're tolerating the demands of training, they're back to competition, they're kind of sustainably playing sport, the return is complete, if we want to say that. Is there anything in particular that, like, with these you might want to monitor for a slightly extended period of time, beyond that kind of end goal that we've got them to, or you got them to?
Yeah, I think, I mean, I paid a lot of attention to his quad strength through this, and we do that for ACL. We should be doing it for any knee-related post-op course, because we know when that knee swells, that quad just does not want to work. The brain tells it to stop working. So I think I did a relatively decent job in monitoring him in different ways throughout the rehab as it related to his quad strength. But I know, not necessarily particularly from him, but from other athletes that I've worked with, if you go and retest them again as it related to some of those isolated strength measures after they've returned to sport, they tend to regress. And I know that this kid, unfortunately, even now will deal with a bit of that swelling returning. So he's always kind of fighting that inhibition battle. And so if there's a way to regularly monitor that, I think definitely not as frequently as I did it, but just to make sure you're keeping up with it, you're maintaining it, I think it will help him in the long term. And so it would be very interesting to see what he looks like now that he's operating at a very high level. Be interesting to see what it looks like.
Yeah, and I feel like, void of the specific injury context, like any, knee-related injury, if it's reactive post their return to sport, then there's going to be some sort of like bumps in the road and, logical reasons as to why, like, maybe even months after the rehab, maybe their quads get a little bit inhibited from time to time. And I think it's natural that you might see maybe some of these progress to things like patellofemoral pain afterwards with, that going on potentially. Obviously, these aren't like a type of injury that you can be in a clinic or a team and see lots of MPFL injuries like you can in ACL in sport. Is there anything that you think, I know this is a horrible question, if you were to see another one of these, or you were to build out a framework that other people might be able to kind of, not copy and paste exactly, because every case is different, but is there any kind of commonalities that you might extract from that process you went with that athlete and try and duplicate or build into a framework for another case if you could?
Yeah, I think, some of the things that, we did really well in this case related to just constant monitoring of objective measures and making sure that we were progressing in an appropriate way. It was really interesting to see how, and back up a little bit, I was able to get some baseline measures for him as it related more to performance, some jump metrics, some sprint metrics, very low level baseline things. But again, this was a high school athlete, so I didn't have access to a lot. And then I did some baseline isokinetic testing with him as well, and some force plate testing with him. So I had an idea of where he was operating towards the end of the season. And it allowed me to have a little bit of an anchor to say, okay, this is where you were. I want to go above that. I don't want to return you to the point, where you were operating when you got hurt. I want to return you better. So that allowed me to have somewhat of an anchor. So I think that that's beneficial. I would say if you have the opportunity to, especially in these settings where these kids come from high schools, you don't have a lot of resources. If you have the opportunity to get any anchors for yourself, I think it's beneficial. And then from there, if you do or don't, just regularly test them to make sure that you're moving in the right direction. Test them in the things that, you think they're going to do well, and test them in the things that they're not, just to get a real baseline. Don't be biased, and just explore your resources there. As far as the things that I think that I wish I would have done better, I would say I was relatively basic in the metrics that I looked at specifically on the force plate. And I'm in a setting now where I'm very lucky to have a performance director who's a genius at this. And I look back at some of the things that I was investigating, and I'm without a ton of baseline data, I don't know that I should have been looking at these things and thinking that they were actually changing because we were actually making an improvement in this guy's rehab, or it's just because he's actually learning how to jump appropriately. So I think in hindsight, I probably would have looked at a few different things on some of the similar tools that I was using. I would say, just like we were talking about before, I think it's really important to be in tune to how they're feeling throughout this whole process, especially as it related to pain and the patellar lesion, and communicate also with your surgeons or your people that really know the biological healing timeframes well, because you might have to get a little bit creative when the research doesn't support very clear thinking. And that's kind of what I had to do here. I had to kind of pull the resources from a bunch of different places and get creative and make sure to openly communicate with people that I thought could help me brainstorm this. So those are some of the things that come to mind when you ask that question.
Yeah, it sounds like one of those kind of cases where actually like having a good relationship with the surgeon is even more important than perhaps normal, just in terms of the surgeon's going to have had a lot more reps of operating on these than probably most physical therapists are ever going to have of rehabbing. And I know that's kind of true of all orthopedic conditions, but this probably more than most, I'd imagine.
Yeah, I think we learned a lot from each other through this process. I don't know that he's ever seen anybody use the the isokinetic dynamometer quite as much as I did. So yeah, it was definitely a really healthy working relationship, and I'm really thankful that that was the surgeon that was on that case, because I know that it's not like that. But if you have the opportunity to lean on that type of a person, if you have the opportunity to reach out to an expert in the space, because you know even though we're here talking about this case, I wouldn't necessarily consider myself an expert at MPFL reconstruction. I had to rely on a lot of my mentors as well through this case. So no matter how far you get into your career, and I'm very early, I think it's really important to lean on those people, because there are still a lot of things that we don't know, and maybe they've seen it. So reach out to your peers, reach out to your friends. They've probably seen it, and just keep that open line of communication for sure.
And I guess this is another cruel question. And by the way, I really appreciate the transparency. I think these conversations are really valuable, because your honesty of like what went well, what could be done better, those things. I think that there's probably things that lots of people who have managed MPFLs or might manage them are going to come across. So I think there's a lot of universal truths here. Is there anything that you think are maybe even maybe either misconceptions or like common mistakes people could make with these injuries?
Well, it seems like if you look at the literature about people returning to sport at 6 months, who knows what they were using for criteria to return these kids to sport. I'm in a setting now where we are crossing all of our T's, dotting our I's. We're very, very specific. But if you go back to the setting where I originally treated this kid, a lot of that doesn't happen. And so these kids are probably returning to sport maybe a little bit sooner than they should be, just based on their functional deficits. It's hard to say from some of the literature because it is relatively limited. And so I think that could be a point of reflection for anybody that might be doing this specific type of case, whether it be, you're pulling from the ACL literature. I think that can be very helpful for determining some of this functional criteria that they should be reaching before they return to sport, because it's not like you're probably, at least the last I looked, you're not going to go on PubMed or ask ChatGPT and it's going to have very clear criteria for you. For specifically MPFL, it's often going to be pulled from other knee courses. So just like I keep saying, be creative, understand the biology, and try to get their function back to as best as possible. Test, don't guess, I guess is what I need to say about that.
Yeah, I think there's definitely other injuries where there's lots of schools of thought, or there's multiple experts, if we want to say that, like, who have managed lots of these injuries and have published research on them and consult to various teams for different for seeing these types of injuries. This is definitely one of those areas where I don't think I've come across anyone that's gone, I'm the MPFL guy or girl that consults the sport on these. So, it's hard to get that kind of like steal that wisdom from experts that have come before you.
Yeah, I mean, and if somebody is scrolling, sees this podcast, and they're like, "Oh my God, uh, I am the MPFL expert. Let's see what this person has to say," and they completely disagree with some of the stuff I've said, please contact me. I'd love to learn more. Again, this is not something that I see a ton of volume from. Had to be creative about, so I'm always trying to learn and trying to be better in this space. And just like you said, you cannot see some for a really long time, and then they might pop up onto my schedule. We do have some kids, in where I'm working at now that do fit the age range,
Yeah.
so you never know. Always to be prepared. And you could take a lot of this stuff into the other knee post-op courses. So, yeah.
Well, Hannah, I'm really grateful for you sharing this case, because I think it takes a lot of nerve to kind of come on a show and have someone just rattle you and ask you questions about what you did, why you did it that way, especially when it relates to a real case. So your honesty and transparency is, very, very appreciated by me, and I'm sure the listeners as well. Where can people follow you and kind of track what you're up to, and perhaps contact you if they've got an MPFL case that they want to bounce some ideas off?
Yeah, and to that MPFL expert that I called out a second ago, please, if there's something that I can learn, reach out to me as well. I'm pretty responsive on Instagram. It's just my name, Hannah Marchant, with a 9 at the end. You'll see my last name is different on the screen now. I got married in July, so Hannah Gladys. You can also look that up as well, but the tag is Hannah Marchant 9. LinkedIn, I'm pretty frequently active on there, and I don't really get on X or Twitter or whatever you call it much anymore. So one of those two platforms, please reach out to me. I'd love to learn from what you have all seen, because chances are I'm probably going to see it again. So if I can help you, you help me. I'd love to learn as much as possible.
Cool. Well, thank you for your time today, and thank you for coming on, and thank you very much for letting me grill you. And I think there'll be a lot of people that got a lot out of this episode. So thanks for your time.
Thank you so much.